You are connecting the emotional component of dentistry to smile. That's where you are able to create magic in the results. What do we get to see here? This is also dentistry, where anterior PFMs are done. I mentioned yesterday as well, I don't do anterior PFMs because I will not get it done in my mouth if a case demands. I will not be doing that in my parents' mouth if a case demands in them. So I will not do it in anybody's mouth if an anterior restoration is required. On the other hand, we also get to see a crown with pink ceramics because there was a deficiency of soft tissue. The idea was correct, the concept was correct, but the execution was not correct. Because the execution was not right, you see the result. It actually has created a buccal dehiscence. Many a time, this is what happens when you plan on the chair. You look at a patient and you start planning in the head while the patient is on the chair. So many a times, what you plan never actually happens. What is the final result seldom matches what you plan. That is why it's always said, either you plan to succeed or you plan to fail. But for either instances, you need a plan. So you better have a plan which will help you succeed. Next, please. So when I talk about succeed, there is something known as you need to achieve success in dentistry. For success in dentistry, how to prep? That's unfortunately what everybody's mind is to achieve success. That if you learn how to prep correctly, you will have successful results. But unfortunately, in the parameter chart of what constitutes success, success in terms of preparation is at point number 4. How do you diagnose a case is of utmost importance. That's when for all the students, just remember, you're posted in different departments. Every department is of a different subject. Every subject will have its own textbook, and every textbook will have a first chapter on diagnosis and treatment planning. Because you cannot bypass diagnosis. If you can't diagnose a case, you can't design your case. If you can't design something, you can't preview the end result even before you start. And if you can't preview, you can't foresee, how do you know where you want to head? How can you achieve results which are predictable? How do you achieve results which will have long-term success? Impossible. That's why I showed you earlier, what you plan and what you achieve, there's a huge gap. Because you have not planned well, which involves diagnosis, which involves designing, which involves previewing what you've done before you finally execute. Next, please. Steps for lab communication. Many a times we tell the lab, we need a crown, we need this, we need that. That's not enough. If the lab has to work in unity with you to deliver a good result, which is technically, aesthetically, functionally correct, you need to have these things of paramount importance. You need to send photos to your lab, which is also what you take for your diagnosis. You need to have diagnostic impressions taken for you to diagnose and also the lab to know what is the case starting with. You also require an establishing the incisal edge position through a mock-up. Why do we need the edge position for the incisors? Because that is what is going to dictate your aesthetics and phonetics. Length of your central incisors, because that is what is going to be dominating your smile. That is where your dictation of the smile line begins from. So again, you have to focus on getting the length of the centrals right and a phase bow transfer. Yesterday, even for the pre-conference, I had mentioned any and every case which crosses the midline in my practice, I'm going to be using a phase bow transfer. Whether it is using my articulator, which is a semi-adjustable articulator, and using a phase bow, or I will use a digital phase bow and combine that with a digital articulator. But there has to be at least a semi-adjustable articulator when you are going to be crossing the midline. Again, we have somebody who's very famous on the social media, eventually turns out to be friends, and the friendship will have its own evidence. Can you play the video? Second one.
Wow, what a question.
you have over exceeded their expectations. You cannot imagine making a reel with a celeb where the comfort level is not there, where the trust is not there, where the confidence is not there, and when your work has not gone to their expectations. So important to understand, trust and confidence takes time. Invest in that time. Don't be in a hurry to start the case, because remember, haste makes waste. The hurry you have to start, you're only moving towards failure. I hate repeat work. So for me not repeating, I have to check mark every single box where I feel failure can occur, which takes time, which means efforts. Next, please. Let's look at the case. What do we see? Patient has few old composite restorations. We see a top-down view to understand if the current incisal edge position is breaching the inner vermilion border of the lower lip. That's a close-up shot. What do we understand when we change the contrast? By changing the aperture settings or the F value. We see the old restorations are already discoloring. There is secondary decay which is present, and it's almost approximating the pulp. So this is the combination of treatment which is required. We go closer, and what do we see? The previous dentist forgot to create the contact areas. And if the contact areas are not created, what will happen to the interdental papilla? It will start to recess. And the most difficult part to recreate, as per David Garber, is the interdental papilla. So what do? We go back to the drawing boards, understand the sill-out forms, go to the wax-up, redesign and recreate what we want as the end result. Again, yesterday we were focusing on a 3-planar reduction for the central incisor. That's how the wax-up also should be. Looking like the final result based on how we want to replicate the final result. Then we do an index. That's what everybody did in the hands-on session yesterday. Create an index to know what is the starting point. And then we start using the burrs. You can see a black spot. That's not a beauty spot. That is a retraction pod in place. And I use a double retraction pod technique. These are the burrs which we have. We don't have time to discuss on the burrs. But what I do for my veneer preps is I use at 70% power, just to make sure there is no fracture of the enamel rods. So this is how the case was as we started. This is a close-up shot of the preparation. What do we see between the preparation? There is a good angle of convergence of up to 6 degrees, which means there is relative parallelism which exists. A top-down view of the preparations where you get to see a 360-degree same hemichamfer margin which exists, which is supragingival from all the sides. You also get to see a miniature tooth which exists circumferentially. And then that's where your mock-up comes in, which is exactly matching your provisionals. Again, you have to check for phonetics and aesthetics to verify that your wax-up is almost the same like your mock-up, which is almost the same like your provisionals, which will be exactly the same like your finals. That's how it looks in the mouth. This is my choice of materials. It has to be BPS, which is vinyl polysiloxanes. Again, preference is acetyletones and polyethers. Look at the margins. Look at the second retraction pod in place. Again, you get to see if it's supragingival, it stays supragingival. Look at the impression. You are not just able to see the margins, you are able to capture the entire gingival sulcus. A close-up shot for you to understand that it's the entire sulcus which is captured. Why is this important? Because your technician is now going to be understanding where to create the emergence profile form. So you are doing this not for you, considering the technician who will never get to see the patient. For him, the patient is the model, the cast, the die, and you have to help him execute his work properly by making sure all the minute, finer details are captured correctly. Choice of restorative material. In this case, we had lithium disilicates which were used, which was an incisal cutback technique. Retraction cords in place, and in this case, we have rubber dam, just like we have for all isolation cases. We remove the provisionals, make sure the surface is polished and clean, try it out, and then you start with the hydrofluoric acid etching, silane coupling. You don't have time for that. In short, this is how the case started. This is how the wax up looked, and this is how the final result looks. A black and white contrast for you to see the transitional line angles, the mamelons, the halo effect, and more importantly, symmetry of the left and the right. And what do we get to see here? We get to see, have we breached the inner vermilion border of the lower lip? No. Which means what we had planned and what we've executed, we have achieved everything as planned. This is again in smiling view. You see Divita Rai, who's leaving tonight for Miss Universe. Hopefully, she'll be able to get the crown back, just like Anna Sandhu last year. Prepping, when we are talking about preparations for all the people who were there yesterday and for those who were not there, what are we focusing on? Maintaining the arch form. We are looking at identifying and correcting the tooth position and combining the scientific principles and concepts with your artistic touch. Because if all of us have to compare ourselves, we all have central incisors, lateral incisors, canines, premolars, and molars in the same order, in the same proportion, but still the smile doesn't look the same. The teeth don't look the same. The face doesn't look the same. So we have to characterize every individual, every smile based on what the case demands. Provisionalization is a must. I have seen so many people who don't give provisionals or temporary crowns because they say the tooth is dead. The tooth is root canal treated. Sorry. A patient who comes to your practice has to walk out with a tooth, whether it's provisional or final, immaterial. But he has to walk out with a restoration. Occlusion, we don't have time for that, but occlusion is going to be making or breaking the life of your restoration, which is on balance, on distribution of forces, and having your intercuspal harmony. Consultation, this is what is going to be your game changer. You might have the best of skills, you might have the best of knowledge, you might have the experience and the expertise, but you can only execute your skills, knowledge, when the patient says yes for the treatment. So even soft skills are very important of how to understand the person and help the patient understand you. All of this together builds confidence. And last but not the least, thanks to the previous speaker, facial aesthetics is the goal. Remember, whatever you work on the tooth, whatever you work on the teeth, whatever you work on the pink and white, ultimately has to blend with the smile, which has to blend with the face. That is why facial aesthetics always and always should remain the goal. So also, we have somebody who comes down all the way from Uttarakhand. We have amazing dentists in Rishikesh, and we also have amazing dentists present in Dehradun. But she'd still travel all the way from Uttarakhand. What did we do? We just made sure we add a beautiful smile on a beautiful face. And what happened? Play that video. We had a very beautiful, stunning 64-year-old lady who comes to the practice with this photograph and asks me, do you like her? I start blushing. She looks pretty. I said, of course I like her. She asks me second time, do you like her? I thought probably she didn't hear the first time. I said, yes, I like her. She told me, you really like her? I said, yes. So I was expecting that she is planning for some matchmaking. But then she says, this is how I looked when I was 28. And then I became very serious. And that's the reason I'm so serious in life. Okay, moving ahead. So I said, now why are you telling this to me? She said, this is how I looked when I was 28. I said, I heard you. You don't have to repeat everything twice. I'm already heartbroken. How much more you want to bring? She said, this is how I looked when I was 28. And this is how I want to look at 64. The first question which came to my head, is she well oriented in time, place, and situation? Common sense, right? But she was very well oriented in time, place, situation because she's the Counselor General for the United States of America, based at Bandra Kurla Complex. She has sense. She has a lot of sense, right? She was very clear, can you do it? If I say yes and I don't do it, I will never be able to visit the United States of America. And I'm a faculty member at the University of Columbia. So I have to visit once every 3 months. So she asked me, can you do it? She looked through me. She scanned me with her retinas. So what do you think? We did it? There's a beauty which says, learn to say no if you can't do it. I gave you a hint. What do you think? Did I do it? No? What do you think? Did I do it? This is how we finish the case. That's pink and white aesthetics. Next. We had Dr. Parmeet, who's also a fellow prosthodontist, 3 years senior to me. He was talking about direct buildup with composites. In this case, there's a midline diastema and fractured fillings. We quickly go through this, and then you see this also constitutes part of smile design. It's not just ceramic every time. Even with composites, good hands, good skills, good material, good techniques, you can still get good results. So this is how you get the wax up done. This is how you create the index. This is how you section the index. All of the people who were there for the hands-on yesterday, do you remember this? Next, please. This is how you understand what is the shade verification. You create a bevel, isolate with rubber dam. This is when you start etching, create a palatal shield which is made in enamel. Then you make sure everything is layered step by step until you achieve the final result with composites, direct build-up. And that's how the end result looks like. And that is Rob, who had come to India at the Delhi University but still chose a dentist in Mumbai to sort out his smile. Another beautiful girl who works for the FDCI, Lakme Fashion Week. She was hell-bent on ceramic veneers. But the problem was not with her teeth only. The problem was also with the predominance of the premaxilla. So it was a clear-cut case of doing orthodontics, setting the premaxilla, correcting the bite, and then making sure you're also closing the diastemas, which we did. And what we did at the end of orthodontics is nothing but teeth whitening. So effectively, it's pristine enamel, native enamel, which is not bred. A prosthodontist whose hands and fingers itch to hold the burr, to hold the aorta, refused to use the burr here because the case did not demand any reduction of native pristine enamel. Next, please. That's how she looked. End of orthodontics, end of teeth whitening. That's the result. No veneers required, no preparation required, no prosthodontic intervention required. And still the case is closed. The patient is very happy. That's how she looked. She can't stop smiling. Next, please. Another superstar She is all over the internet. She also happened to have a beautiful smile for which people compliment her in and out. And of course, the only person who is not smiling the way she is her smile expert. Many cases where I told you it's understanding the material. Whether you have to go with lithium disilicates, whether you have to go with feldspathic porcelain, or whether you have to go for lucite glass ceramics. It's the decision you need to make to understand what the case demands. And that is where, if you're able to identify what needs to be done, the results just look fabulous. It's a pristine result where direct composites failed. The patient did not want to have direct composites. In this case, we decided to have feldspathic porcelain, and that's a perfect finish. Another case, diastemas present, we closed it, the entire look changes. She's the only patient who did not consent me to use her entire facial photograph. But I'm also very smart, I will cover the eyes and still use the photograph. Missing tooth. One of the common things what is taught even to an MDS prosthodontics is a 3-unit bridge. Since 2017, in my practice, I don't do bridges. Why I don't do bridges? Being a prosthodontist, I don't do bridges. Because God forbid, my family requires an anterior missing tooth to be replaced. Will I do a bridge in their mouth? The answer is no. If I require a missing tooth to be replaced, will I do a bridge in my mouth? The answer is still no. So if I will not do a bridge in my mouth, my family's mouth, I will not do a bridge in the patient's mouth as well. So in this case, and in all cases for missing teeth, it's a dental implant. Here you can see, I have removed the entire case because of paucity of time. Fractured tooth, patient fell down while shooting for an advertisement for a motorbike. What an advertisement. Fractured tooth. What we had to do? A socket shield, grafting, implant, immediate provisionals, maintain the entire gingival architecture, the osseous crest, osseous bone, sufficient healing, and then a screw retained final restoration. If you look at the top, look at the soft tissue profile, look at the implant crown, which is screw retained, absolutely pristine. This is also in the aesthetic zone, so a part of smile design. Another case, edentulous, like a football ground. The most difficult part to recreate is the interdental papilla. What did we do? We have had the entire cobalt chromium framework and have the Paolo Molo concept used of zirconia crowns. Look at the pink and white. If you only look at the top, you would feel, oh, probably these are natural teeth. Probably these are tooth-supported restorations, but there are no teeth present in the mouth. These are all implant screw-retained restorations. Look at this. Front tooth came out when the patient was kickboxing. So all of these sports can also give you business. Remember that as a businessman. So his kickboxing proved to be your business. So encourage people to participate in sports. Coming back to the topic. Again, have a look at the pink and white aesthetics. It looks a mirror image, a perfect match, where the interdental papilla were preserved. In the previous case, I showed you it was regenerated. The goal remains the same. Pink and white aesthetics cannot be compromised. One of the most difficult cases is malalignment. And the shortest treatment possible is extract few teeth, intentional root canal on few teeth, and do crowns and veneers. Ask yourself, will you do this in your sister's mouth? Will you do this in your mouth? How dare you suggest such an option to the patient? How can you sacrifice good teeth because it is not in alignment? You have to suggest orthodontics for such cases. Overlapping present, Invisalign, the case is sorted. maintenance and longevity of your natural teeth, which is considerably enhanced once they are in correct alignment, versus intentional root canals and doing horrendous work with crowns and bridges and not having any tooth left for it to have life in the future. Next, we will open this. Next, another beautiful girl, fantastically looking, travels all the way from Kolkata. We have amazing guides present in the entire West Bengal. Still, she traveled across from the east to the west. And what did we do? We just made sure she has a beautiful smile on her beautiful face. And what was the end result? Play the video for cases where things look straightforward. This is what we need to do, this is how we need to solve. By the way, I'm 27 minutes into the presentation. Hopefully, 45 minutes. Next, please. What do we understand? Understanding the teeth at rest. How much of the visibility is seen at rest, which will vary depending on the tonicity of the lip and the amount of lip thickness. Then we have to understand at full-blown smile how much of the teeth are seen, how much of the gums are seen, and you can see 3 cases finished. All of them look different, but still there is a common element of maintaining the balance with the lower lip. Cant and midline. People, what will they do in this case again? Intentional root canal followed by a crown just to match the midline. They don't remember what Miller and Borden had published in 1979. We'll come to that. Width to the height proportions, again, very, very important. As I said, central incisors are going to be dominating your smile. So we need to have at least an 80% central incisor tooth. Gingival zenith, which is the highest point along the gingival margin, distal to the midline, is what we need to identify if it exists for a seamless central incisor and a perfect smile line. Incisal edge position, as I already mentioned earlier, is based on your phonetics and aesthetics to determine you're not breaching the labiodental sounds. Axial inclination, all the teeth will have a slight mesial tilt to make sure there is aesthetic value which is added. Incisal embrasures, because we want central incisors to dominate the smile, the incisal embrasures for a central incisor is going to be the smallest. And as we move away from the central incisors, the proportion will start to diminish, embrasures start to become wider. Surface texture, I have seen so many people do so many restorations where the surface is absolutely smooth. That is when the patient smiles under different lighting conditions, that smooth surface stands out because none of your teeth are otherwise so super smooth. Shade, this is where people go wrong. We don't have time. So what I would suggest everybody to stop going by what somebody has told. What is somebody who has told? Shade has to be taken in broad daylight. Have you heard of this? Yes or no? How many hours do we have in a day? 24 hours. Out of those 24 hours, how many hours do you sit in broad daylight? How many of you go and sit at Sabarmati riverfront? Broad daylight is what? Beach, park. Out of 24 hours, how many hours do you spend in broad daylight? But shade has to be taken in broad daylight. Logics have to be correct, have to be practically implemented. And that is where things go wrong. The most difficult part is to replicate the single tooth restoration shade with the adjacent teeth. Why? Because it's taken in broad daylight. Component number 2 which goes wrong, they will take a shade tab and look at the tooth. Oh, this is the shade. If this is the shade, what is the hue? What is the chroma? What is the value? No idea. Right? So for all the ideas, go on YouTube. Watch a 40-minute lecture free. Yeah, you'll understand that shade is not what you just see. There's shade of the final restoration, which will include hue chroma value. You have to shade the shade of the prepared tooth, which is a stump shade. You have to take the shade of the block, which is going to be milled or pressed by the lab. You have to take the shade of the final luting cement, because you do not want that shade to act as an opaquer and block the light from refracting, reflecting, and deflecting. Femina Miss India, Delhi. We have a lot of beautiful, amazing dentists in Delhi as well. What did we do? Added a beautiful smile on the beautiful face. So what is an attractive smile on a beautiful face? We need to understand what Miller and Borden have said. 1979 from the JPD. A variation that is less than 4 mm is not noticeable to the human eye. Forget general practitioners. And facial and dental midlines only coincide in 70% of the population. And it fails to coincide in 75% of the population, which is the upper dental and the lower dental midlines. And people will trim just because it doesn't match. Only if you are treating a case orthodontically and with complete dentures, which is ridge supported or implant supported, that is when you need to have the dental and the skeletal midlines coincident. The most handsome guy in the world, Tom Cruise, has a 2 mm discrepancy of his dental and facial midline. How many of you knew this? Hands up. Not even 10 dentists know this, and we expect the world to realize. Next, please. So what are we looking at? This is what we want on the left and the right side. Next, please. Any change in the shape, it will be glaring to the eye. One slide back, one slide back, one slide forward. Okay. Back, forward. Did you understand the difference? Just with the shape going wrong. Next. This is where the proportion goes wrong. Where a central incisor is not looking like a central incisor, it will again be glaring to the eyes. Next, please. The arrangement is wrong. Central should dominate, followed by lateral, followed by canine. But it's your centrals and canines which are dominating. Lateral is way too small. It will again be glaring to the eyes. You want things to be seamless, not standard. Another beautiful girl who had quite a decent work done. Next, please. And what do we see? Pretty decent work. Next, please. Until we go closer. And what do we realize? Interdental papilla are missing. And what do we see? Even excess residual cement is left. The dentist did not even have extra time to remove the residual cement. Which world are we in? Next, please. And what do we see? There is something which is fractured in the region of 2-3 or number 10. But luckily, the patient had a low lip line. Next, please. Low lip line. Correct? So the case is saved. That dentist has saved his face. But look at the eyes. Is she happy? Eyes will tell you the amount of happiness, not the teeth. And that's where you realize happiness is deficient. So what do? Create a simulation, identify what will be the final result like, understand in digital equilibration what caused fracture of the restoration in the region of number 10 or 2-3. And what do we realize? There was an interference which was present, which was causing deviation of the jaw in maximum intercuspation. What did we do? Only remove that interference, made sure it is still a contact, but interference is removed. And then that deviation almost became linear. You can see there is an imbalance of almost 40-60, which is now almost 50-50, with just one interference removal. Now imagine putting a red or a blue articulating paper and everything looks red and everything looks blue. Which one is a good red? Which one is a bad red? Point upon red. Then we go back to the drawing board because we are crossing the midline, mounted onto a semi-adjustable articulator. This is a wax up which is going to be from 5 to 5, 10 teeth, and we do a mock up in the mouth. The moment we do a mock up, look at the eyes again. She now looks happier because she feels the results are working. And this is going to be staying in place for at least 4 to 6 weeks for the soft tissues to heal, stabilize, mature. And what do we see when we go inside? Interdental papillae are back. They are coming back. They had disappeared. They are coming back. And what do we see? Still no interference with my mock-up, which is my bisacral. Still no interference, and the patient is starting to feel happier. Soft tissue is starting to grow back. The material is just bisacral. And then we start preparation through the provisionals using the Gallup-Guerence APT technique. And then we give a provisional set. That is how we start building the cusps. That's how we define the transitional line angles. This is how we create the surface texture. We create the mamelons. This is how it looks on the cast. This is how it looks on a die. This is mounted on the cast. The southern views of the cast, and let's see how it looks in the mouth. This is how it looks in the mouth. Pink and white aesthetics. Pristine from the left and from the right. A top-down view for you to understand. There is symmetry, there is harmony, there is balance, and there is proportion. Close-up shot of all the teeth for you to know what work goes in to have such results. And what do we see? There is no scope for overconfidence. We still want to check and re-verify whether the final restorations have caused any interference. I do not want all the good work to deteriorate by one interference. We all know interferences can also cause malalignment and jaw issues over a period of time. We do not want that. And this is the patient. When I asked her to stay steady, she can't stop smiling. And when I tell her to smile, this is how she looks when she is happy. Look at the eyes, and suddenly the lower lip line is a high smile because she is happy. This is how she looks in the side-on views. When I show such photos, people think I do matrimonial photographs as well. No, I don't. It's only purely dental work. And this is how it looks, which is still maintaining within the inner vermilion border of the lower lip. This is how she looked when we started. This is how the case was. Tamil Nadu, Andhra Pradesh. We just sorted her smile. Ultimately, she also ended up being the Times Miss Beauty with a purpose. How can implants not be there when we are talking about the anterior aesthetic zone? Again, the concept of white was done correctly. Teeth look proportional. But look at the pink. The idea was again good by using pink ceramics. Two problems. Number one, cemented restoration. In my practice, 99.9% of implant restorations are screw retail, not cement retail, which means retrievability is easy. 88% of implant failures occur because of peri-implantitis, as published by Adel in 1981. So I do not want failures. I know what can go wrong, so I will avoid all of that. And what do we get to see? We get to see there is still bio-os which is present, which means the previous dentist did try bone grafting. But remember, it's always a dual zone grafting. It's always bone grafting in combination with soft tissue grafting. Whether you're using a connective tissue graft or you're using a PRF plug or a combination of both with growth factors, it still requires soft tissue work. And what do we get to see here? Screw retail restoration. The entire case is taken out just for you to see the end result. This is how the contouring is modified with the help of provisionals, which means there is emergence and submergence profile in a temporary, which is copy-pasted and replicated in a final restoration, which you can see will have a screw retail restoration which emerges out from the palate. And when you look at the soft tissue in the mouth, look at the soft tissue thickness. Look at the peri-implant view. Look at how healthy, stable the gums are. And when you add a restoration to it, it is going to last. It is going to stay. It is going to function. And more importantly, it looks natural because it is in the anterior aesthetic zone. See the soft tissue thickness. And for all those who forgot how the case looked, this is how the case started. This is how the case was finished. Pink and white aesthetics in the anterior aesthetic zone also constitutes smile design. A beautiful girl all the way from Kanpur in Uttar Pradesh, right? Ended up being the Femina Miss India 2022 second runner-up. Another case, look at her. A very, very pretty person who is heading Morgan and Stanley. And what do we see? She already got a full mouth rehabilitation done from someone which is not even 2 years old with zirconia restorations. And there is no bleeding on probing, there is bleeding on touching. The gums are that inflamed. So what do we learn from this? If these are zirconia restorations less than 2 years, which means resin cement was used. If you have to take them out, I have to section the restorations. I am expecting over aggressive preparations. There is a chance when I take these out, there will be further loss of tooth structure. There is also a higher chance that tooth structure might be sacrificed. All of these things you have to keep in mind. So what do we do? Look at it. The gums are bleeding. And what are we going to do? Replace the bridges with bridges? No. Replace the missing teeth with implants, depending on how is the soft tissue and the hard tissue availability. Augment that as well. These are the lowers, again, bleeding from everywhere. So you still go back to the drawing board, create a sill-out form, create an outline, and these are zirconia restorations again. Look at how it looks in terms of translucency, in terms of translucence, next. In terms of the occlusal anatomy, these are anatomic teeth of 33 degrees, not trimmed and made anatomic becomes monoplane. This is how the case started. I removed the entire case again because of paucity of time. This is how the case started. This is how it looks after 1 week. This is how the transition happened from outside the mouth restorations to in the mouth. And I'll show you an 8-week follow-up, which looks as this. The healing gums have healed. Pink and white aesthetics sorted. Let's look at the upper. Again, you can see the screw access holes present where they should have been. You also get to see zirconia abutments which were used. Again, screw retained. You can see the screw access holes. This is how the restorations look outside the mouth, and this is how the case is finished. Full mouth rehabilitation, which had gone haywire, is back again in terms of aesthetics, in terms of function, in terms of longevity. Let me show you a 7-year follow-up. This is how it looks. And when we go closer after 7 years, it looks as if these are natural teeth or veneers on natural teeth, but it's a combination of tooth-supported restorations, screw-retained implant restorations with perfect pink and white aesthetics. Play this video. modeling, fashion, pageantry, Bollywood, anything you name. Everybody looks for a good smile. Which means if you feel dentistry is out of business, think again. Look at this, composite restorations. 4-year-old. And what do we have? Stains, chipping, cracking. And what did we do? Single day dentistry. We delivered restorations at the end of the day, starting at 9 a.m. in the morning. This is how we design completely on Exocad. This is how we have the printed models ready. We verify where we wanted and what we've achieved. This is how we do a mock-up in the patient's mouth. Then we start scanning just to understand how the restorations are. We start milling it chairside. Once we have the restorations fabricated in the mouth, this is how it looks outside the mouth. Remember, these are lithium disilicate restorations, blue in color. So once they lose the water of crystallization, that is when the original shade comes in. That is where we start staining and polishing the surface. And the restorations, I will not show you a post-op, I will show you a 1-year post-op. This is how it looks after 1 year. Pink and white aesthetics. A 1-year post-op, perfect blend of pink and white. A top-down view again for you to see we've not reached the inner vermilion border of the lower lip.
Get you on my side.
Even if you don't want, I will be. Right? That's my job. Secret number 1, learn how to diagnose the case correctly. 40 minutes up, 5 more minutes. I said I'll finish in 45 minutes. Learn how to diagnose the case correctly. If you can't diagnose the case, don't take up the case. Because you are only going to fail. And failure in these people is a big failure. Remember, it takes years to build a name to have credibility. For all of it to be lost, it requires one case. Let your next case not be your last case. Next. So stop looking at teeth and gums as a dentist. Start looking at the entire stomatognatic system as a dentist. Which means the focus has to be on the muscles, on the joint, on the ligaments, and then on the teeth and on the gums. Number 2, investigations. Now, when I say investigations, people will say medical investigations. No. For medically compromised patients, you require medical investigations. For every other patient, my investigation involves an OPG. Why? Because I will take an IOPA only when I suspect something is wrong. I don't do guesswork in dentistry. I will take an OPG to understand what my naked eye couldn't see if my X-ray is showing. Leave all the chances, any open door where failure can come in. Phase bow mounting, as I said, for every case which crosses the midline, I will do a phase bow transfer. Whether it's digital, whether it's analog, it will happen. I need to know my orientation relation. I need to know how my maxilla is placed to the fixed cranial base. If I don't know that, what am I doing? What am I rehabilitating? What makeover am I talking about? Photographs. Photographs are a must. You need to know where you are starting from. You need videos. Without this, you are not heading anywhere. Look at her, posing with Sonu Sood, one of the top stars of the Tollywood, Telugu film industry. She also requires dentistry. She also chose to fly down from Hyderabad to sort her teeth out. Plan. Once you have diagnosis, you require a treatment plan. As I said, you plan to fail or you plan to succeed. In either case, you do require a plan. Frank Spear, one of the top legendary prosthodontists, I also happen to be one of the mentors with the Spear education. Treatment planning is a linear process. It has a beginning and an end. The sequence of the treatment plan, remember, sequence of the treatment plan will often vary from patient to patient, but the sequence of treatment planning will rarely change. Very, very important. This is what dictates my treatment plan and diagnosis. Number 4, it's where you need to create your drawing board. People who make new buildings do not visit the site and say start demolition. No, that's what we dentists do. What do we do? You require a crown, you require fillings, you require this, you require that. By 5 minutes of clinical examination and 5 minutes of discussion. Stomatoplastic system is not that easy. It's the most complex joint of the body. At least give it some time to understand. It takes time. So plan. Whether you're doing the analog way, what has to be the plane of occlusion, how the compensating curves have to be, how do you want the restorations to be, whether these will be the onlays, whether you want to give veneer, whether these will be overlays, endolays, however you want to name it as, but it has to be designed first before you start preparation. You need to have a blueprint ready. You need to understand whether you want a cusp-fossa relationship, cusp-marginal ridge relationship, you want tripodization of the contacts. You have to design it for you to know the results to be successful. Number 5 is a trial. Even when you go to buy something, you try whether it fits you correctly, whether the color suits you. Similarly, for the patient, you have to check the trial. How is the look? How is the function? How is the aesthetics? How is the bite? How are the excursive movements? And then you identify what is the difference and also explain the patient that, see, this is the difference what you are going to experience. So patient is part of the treatment. Patient is not alienated. This is how you are able to understand aesthetics and phonetics at the stage of mock-up, at the stage of trials, without preparation. No preparations have happened as yet. This is where you know what the patient will anticipate. So any corrections will happen here, not at the BISC trial stage. She's from the Tamil film industry. Next, you don't have time. Back. Clear? Next. Next. Yeah. Then comes shade selection. Again, as I said, please go to YouTube, watch this, understand the shade. If you go wrong in the shade, it's a blunder. What looks good on the cast might not look good in the mouth. And that is where failure is bound to occur. A time bomb waiting to be ticked and exploded. Material selection. The biggest problem with everybody is zirconia Emax. Zirconia Emax. This is what we know, correct? Whose advantage is that? Ivoclar Viverdent. I'm a key opinion leader for Ivoclar Viverdent. I'm also doing their R&D, but I don't endorse any brands. Why? Because I speak science. I don't want to brand endorse this. So what am I telling? Emax and zirconia is not everything. There are n number of materials which you have to understand whether these are oxide ceramics, whether these are layered ceramics, whether these are resin infiltrated materials. For you to know that these also exist. Then you also have to understand whether it's a high translucency, low translucency, medium translucency, whether it is a uniform shade with gradations. And what will we say? Emax. Zirconia. Shade A2. We do not know whether we want to layer the restoration, whether we want to stain and polish, whether we want an incisal cutback. Send me the final restoration. So who is the decision maker? The technician, who has never seen the patient, who doesn't even know the patient is a male or a female, a 20-year-old, 40-year-old, or a 60-year-old, no idea. For him, the patient is a cast. And what information you are giving? Emax restoration for this tooth, and this is the shape. Preparation. Remember, enamel. You have to be enamelophilic. Love enamel. Because etching to enamel is predictable in the long run. Bonding to enamel is predictable in the long run. So as long as you are in enamel, adhesive dentistry will work. Which means all your minimally invasive dentistry principles will work as long as enamel is there. So understand how much of enamel is to be reduced, if at all it is to be reduced. And then you look at a cast like this, you understand the entire sulcus is captured, which means retraction was also done correctly, and the correct impression material and the impression technique chosen was optimal. Again, we've seen the preparations, you require a 360 degree, we don't have time to go into all of that. I'm sure everybody knows him because he is the only Mr. World from Asia who also required a dentist before he went for his patch. And he still comes back for follow-up, cleanup, teeth whitening. Number 10 is the restorations. These restorations have to look good, which means you and the lab have to work together to deliver such restorations. And more importantly, what looks good outside the mouth should also look good in the mouth. Whatever be the case, however be the result, it should still look pristine. Symmetry, harmony, balance, whatever be the age group, whether it's a late 20s or a late 60s, whether it's tooth supported or implant supported, the aesthetics and function cannot be compromised. I go back to the earlier slide, success in dentistry, how to diagnose, how to design, how to preview, and then how to prep. Success. Success is a journey. People work hard to reach where they are. And ultimately, when you are happy, you will have two things in common. Crown on your face, smile on your teeth. And there will always be a photo bomber invading photographs. Why? Because he did not contribute to the crown, but he contributed to something else. And for all of you who want to learn how to design a smile, who want to practice on patients, whatever I have said, you want to do it on patients, 14 to 18 January, Mumbai. As I said, we are in an aesthetic-driven world. Things are only becoming better. Makeup material is becoming better. Cosmetic material is becoming better. Similarly, vis-a-vis, dental materials are becoming better. Dental techniques are becoming better. Why don't you embrace it and become better? Who are these people? They've traveled from far away to get their smile sorted because the audition date ends for Femina Miss India 2023 on the 31st of January. So they are all coming to sort their smiles before they take their videos and start uploading them on the Miss India app. They have traveled from different parts of the country with an anticipation, with a dream, with an ambition that when I smile, it should connect with someone's heart. It should be not just pleasing to the eye, it should leave an imprint in the heart. Yours truly. So what is success? Success is just one step away from where you thought I should quit. One step away. So whenever you feel this is the threshold of the problems, this is the most complex case you have done, I don't find a solution to this, will I be successful in this? It's just one step away in terms of patience, in terms of perseverance, in terms of trusting yourself and the divine power right up. Talking about success, this girl did not even know how to speak English. She traveled from a small village which was present where? In Uttar Pradesh. She came to Mumbai, we sorted her smile. She said, I will pay you in 2 years EMI. I said, done. She used my phone for getting her Femina Miss India audition. Want to see the video? Done on the streets. Click. Few months ago, she was a contestant of Big Boss. If you know Vikas in the house, he is also my patient. 2 years back, there was Jasleen Matadu. She is my patient. Anoop Jalota is my patient. All of these people are my patients. Now you saw Prakshi, she's at MTV Splitsvilla. Next. Click. And never stop chasing your ambitions. Let me show you another set of two people who thought there is no hope. But what happened? Let's find out. There are n number of people to pull you down. There are n number of people to throw stones at you. Don't throw your stone back because karma is real. Collect all the stones. Look at those stones every day and make every stone become your next milestone. The same people who used to throw that stone will use the same hands to clap and applaud for it. The best silent reply you can give everyone. Another success story. Reinstilled the confidence, and she left yesterday to represent India at the Mrs. Universe. Don't stop dreaming, because you never know when the Almighty says Tathastu. So only say positive, think positive, and believe in yourself. Thank you everyone for being patient, for sitting till 7 in the evening, For all the people who were there yesterday, it's like a deja vu, right? Which means if you are with me, you will never leave before 7. Thank you to the organizers. Kamal sir is right here. Dr. Anmol, wherever she is, in my wishes. Thank you for having me amongst you. More importantly, for all those who believe dentistry is saturated, there's no scope in dentistry, this is the best time to be in the profession. Try to be the best and believe in the best. Thank you.
lấy nào đau mà
अच्छी बात है तो बस भी ना कम
Thank you so much, sir, for wonderful and inspiring lecture. We are flabbergasted by the lecture and hope many are going to follow your footsteps. Thank you for so much for this wonderful lecture. Next, here we have Dr. Shanil Parasta ma'am. She is MDS in conservative dentistry and endodontics. She is a diplomat in laser dentistry from USA. She is also a speaker and mentor for the laser dentistry across the globe. She is a faculty for the Fellowship Laser Dentistry affiliated with MUSHS University at IDA headquarters in Mumbai. Also, she is clinically director at Laser Multispecialty Dental Lounge, Bandra, West Mumbai. And so she is going to speak for the topic laser in endodontics. All over to you, ma'am. How many of you have already heard me before here in Ahmedabad? One time. How many of you have heard twice? There are hands who are twice, and you are there for the third time also. You are so great. I love you. Thank you. Yeah, sure. So I think you already had a good amount of interactions for lasers till now. You got to have your workshops also. You get to listen to another lecture, correct? So now I am not, of course I'm speaking for lasers, but I'm not going into that depth. This was just a beginning and this was just an introduction to my fancy world of lasers. It is not just the light that comes into it, but the almost outcomes that we are learning and listening to it right now. Okay, are the slides moving? Yeah, perfect. Yes. So since the era of COVID or the pandemic, we have known, experienced, and by far justiced that the non-contact form of operations, whatever it is the best if it comes to protection, right? However, experiencing this non-contact form in your dentistry, let's have a look in a world wherein you will be performing all your procedures in non-contact in a very lesser aerosol-based dentistry, which is not just a minimally advanced and invasive dentistry, but also it is a completely advanced dentistry which you have to experience. Okay? When we start with the laser, everyone here down there already know the acronym? What it stands for? Light amplification for stimulated emission of radiation. When it comes to radiation, we would quickly look into the radiation spectrum. Can you see my pointer down there? In the center, can you see the colors? What is that? These are the visible range of the electromagnetic spectrum. On one side, we have ultraviolet radiations. On the other side, we have infrared radiations, correct? And when you look into the wavelengths, which we commonly use in dentistry, corresponds to all the colored lines. Can you see the blue lines? We have 400, 450, 470 nanometers, which are commonly referred to as blue light lasers. Then in the red sections, we have 600, 650, 670 nanometers, which are oftenly referred to as red light lasers. Correct? Have you ever heard of it? Red light lasers, blue light lasers. And there are something which is called as infrared lasers, or the most commonly diode lasers. So in that section, we have few wavelengths, and then we have mid-infrared region, then we have erbium lasers, then we have CO2 lasers. But why we are looking into the spectrum currently? How it is clinically oriented. The only reason we are looking into the spectrum is all the lasers which we use in dentistry majorly falls into visible and infrared regions. It means they do not belong to the ionizing spectrum. Ionizing spectrum meaning X-rays, gamma rays. Having said that, can I say these radiations or my lasers are non-hazardous radiations? Having said that, can I say, is it safe to use lasers in pregnant ladies? Can I use lasers in pregnant ladies? Yes, unless provided it is a safe trimester. I can do all the procedures with lasers just like in conventional dentistry, provided it has to be within the safe trimester. Okay? Now, depending on the penetration, we have two different forms, soft tissue lasers and hard tissue lasers. Soft tissue lasers, name itself suggests that whatever procedures you are doing is limited to the soft tissues inside your oral cavity. But when it comes to hard tissue lasers, these procedures are not just limited to the hard tissues inside the oral cavity. What are the hard tissues inside the oral cavity? Enamel, dentine, and bone. Yes, enamel, dentine, and bone. So it's not just limited to enamel, dentine, and bone, but it is also we are working on gingiva, oral mucosa, soft tissues, and hence these hard tissue lasers are often referred to as all tissue lasers, and which I personally use in my practice to make it a charm practice. So I think that starts our video. Yes. Till now, it's not a then. Till now, we are using these high-speed aerotols, right? Bursts. But what I do in my practice is this, a complete different non-neural, no contact in industry. So without touching the tooth surface, I am actually preparing a cavity. Okay? And then immediately followed by a restoration. Not just that, am I not only working in non-contact, but at the same time, I am minimizing my time and I am not cluttering my actual workspace by minimizing the number of instruments and the equipments that I'm using. So I'm just not working on the tooth, I am working on the gingiva, on the gums, simultaneously when I'm working with my hard tissue lasers. This is an instance of a class 5 cavity preparations where not just tooth was prepared but also the gingival contouring was done just to get a proper access to all the carious area, followed by a complete restoration. See that? Correct? Now, it's not just a few differences between the drills and the lasers, okay? It's about all different things. As previously in my second or third introduction slide, I mentioned that lesser aerosol, I mentioned about the lesser aerosol based dentistry. How is it possible? Of course it is possible. We'll stop using drills again. We are non-aerosol based dentistry, correct? No. We have this option wherein we can minimize about 98% of the aerosols being produced. And I'm just praying and hoping that again, that COVID second, third, fourth, fifth layer doesn't come up. Okay? It's not just that, it is also selective in ablation. What does it mean? That we are selectively targeting only the carious area, only the area that we want to remove, and getting a completely sound enamel and dentine to work on. And having this characteristic of selective ablation, what can I say? I can say that my absorption scale works very well. So how do I define my scale? I have got 4 different colored lines, blue, white, red, and brown, all corresponding to different wavelengths, correct? Can you see the x-axis here? We have different wavelengths corresponding to different laser types. You can see diodes, erbiums, NDRs, correct? When I see my erbium family, which is often referred to as hard tissue lasers, I can see that they are very well working on and getting absorbed in water and hydroxyapatite. Whereas diodes are getting absorbed in, what is that red line? What is that red line? What is that red line? Hemoglobin. What is that brown line? Hey, come on, just look at the picture, man. It's a brown line, right? So it's melanin. Melanin is what? Any colored pigment. And melanin is the most commonest of it. Any colored pigments and which is there and getting absorbed at the same time is improving our form of working. So hence the absorption of hemoglobin and melanin gives me what? Gives me a clear field to work on without getting so much blood in my operatory. That is, I'm getting a complete hemostasis, correct? We'll see cases and we'll get to see how good hemostasis I can achieve with my lasers, okay? Correct. I am just not doing disinfection, but I am doing everything with my hard tissue lasers. Right from my excess cavity preparations to my cleaning and shaping, along with my disinfection with just laser equipment. One, right? This is how a erbium laser works inside the root canal. Okay. I would like you to appreciate how the walls are getting enlarged, correct? Also, I want you to appreciate the bubbles and the cavitations which are being formed once my laser moves up. So these are the two different phenomena which helps to get a clean and an enlarged canals along with a disinfection protocol which gives with a cavitation effect. I'm not going into the detailed mechanism of what is happening, but at the same time, I'm giving you two. Okay? The basic rationale for endodontics or for any root canal treatment is killing of bacteria. Correct? Why am I doing root canal at the first place? Why am I doing root canal at the first place? Why am I doing my root canal at the second time? For the second place? Infections. The only reason my root canal is done is for taking care of disinfections, antibacterial which are there, right? So if I target my bacteria which are lying down there inside the root canals, not just with a erbium laser or not just with one frequency, I have an option of convincing and getting into these disinfection protocols using another laser, another wavelength, which is a diode laser. This is the most commonly form of lasers used in industry, which is called a diode laser, correct? And did you appreciate it? How different it worked inside a canal when it was compared with the hard tissue lasers? What my hard tissue laser tips were doing? They were actually enlarging the canals. What my diodes are doing? Correct. They are just doing disinfection. Correct? Can you appreciate and see the reach of how laser light can penetrate and reach beyond the apex in the periapical areas, through the lateral canals, through the distal canals, furcation canals, correct? Can I say my light has reached where my liquids can't? Yes. So that's my another added advantage of using lasers in the field of endodontics. It not only gives my root canal a disinfection protocol, but also it gives me a clear field, as in open dentinal tubules. There are no smear layers if I use my erbium lasers. And can you appreciate this? This is something which I am obsessed with currently. Okay. In fact, I am writing one. Soft tissue laser protocols, meaning now I would be describing more about my diode lasers. Soft tissue lasers, okay? First, the first case which we would look into would be a gingival depigmentation case, wherein I can see there is hypermelanin pigmentation here, correct? With the lasers we go inside, this is before and after. I would want you to appreciate this with a video here, wherein in the first video, can you see I've used just, not I have, I'm so sorry, this is not my video, this is my sister's videos. I'm not a periodontist, my sister Dr. Sana is a periodontist and she's using scalpel during her PG days. So that video is technically of her, not mine. So can you see here how a partial thickness flap is being done? Correct? So you get to see all the bleeding. Can you see how lasers are working? They are working, they are touching, they are abrading, but we are not getting a stamp of blood. Correct? My operating field is clear. How about I say I do the same procedure with the diode laser, but this time in a non-contact manner. This is a case of non-ablative. Without even touching the gingiva with my diode lasers, we are able to achieve a completely beautiful pink gingiva. Non-ablative meaning we are not touching. If you carefully see the video, you'll get to see that this is a blue light laser, okay? Working, we are just swiping it out just like a painting brush in a non-contact manner, covering all the areas. Correct? So it's not just non-contact with my erbium lasers, but it is non-contact with my diodes as well, because I am able to do everything with all different wavelengths available in dentistry. Okay? So basically, with all the competitions going across in the manufacturing world of lasers, what advantage we are getting as users? Every different laser company is coming up with something new, correct? So now we have laser companies who have got multiple wavelengths. So I can do all these things. I can work with my blue light laser, do a non-ablative work. I can go ahead and do a photobiomodulation or LLLT with my red light, and again I can go back and do the ablative procedure with the same laser, with the infrared or a near infrared light or a wavelength. Correct? I can do all of these with one single unit. Now it's up to you how you want to process. Right? This is the post-operative view. The lowers were done with the ablative formation, and the upper with non-ablative, 450 nanometer wavelength. 450 nanometer is red light, blue light. 450 electromagnetic spectrum, blue light. I just mentioned that we are doing non-ablative with blue light. Okay? A very commonest of commonest procedures wherein you can see the operculum, you'll go back, you will inject. Yes, in this case you will inject. And then you will laser it off. You have one video for it. Here we are using 450 nanometer wavelength. Simply just like a pen and brush. If you know your laser settings, if you know your laser parameters, then you won't require any other thing, and you can actually work just like with a pen and a razor. Okay? So here you went it all around inside, upside down, and you got it in a chunk. You removed it, and here you get an option to restore it completely in the same visit, same time, and say bye-bye. Vestibuloplasty. So you will get to learn about so many articles showing all the case reports here at this website www.drsana.in. And I'm illustrating for further more cases. You can go back and check those websites, the research section. Here is a comparative evaluation. One side it is done with the scalpel, the other with the laser. Immediately, if you see, you get a clear field. While you're working, you'll get to have a clear field. What does it mean by clear field? Correct. We get to have a good hemostasis. Correct? This is 7 days post-operative with my scalpel, and this is 7 days post-operative with lasers. Okay? Here, after every surgical case, we make sure to do something called as photobiomodulation or LLLT, which helps and fastens the wound healing process. Correct? Now, this is an immediate exposure of tooth for an orthodontic process. Preoperative, go ahead, you make it out, clean, clear, you place a bracket, and before and after. Here you have an unerupted deciduous teeth. For this, what would you do? Before starting, you will take an X-ray. You have a laser unit. You'll take an X-ray. You'll expose it. What do you get? How do you expose and how much you expose? Anyone? Exposure has to be very minimum, not encroaching anywhere in the attached gingiva, because once you do this, there are chances that if you overdo the process, if you remove much of the tissues, then when the tooth becomes actually erupted at its original position, it will have a recession. Okay, so the things have to be considered. This is before and after. The dermal polyp. How many of you have come across this polyp? Is it always the restoration that we do, or is sometimes these cases may turn up into a root canal? Yeah, correct. So whatever it is, what if you touch it with a bird? Have you tried touching it with a bird? Yes? How many? How many of you? Even I did. But then, if you do it, are you successful in doing the consecutive things that you want to do in the same visit? Because of the feeding. So, if you achieve a hemostasis, the number of visits that you're gonna have is reduced to a considerable level. Okay? In cases wherein we are just dealing with some soft tissues, say gingiva, some superficial mucosa, and the areas which are non-keratinized, not majorly keratinized, certainly non-keratinized areas, there the need for injecting the local anesthesia is reduced to a greater level thanks to my lasers. I would not say I don't inject, I definitely inject in cases like operculectomy, because they got to have a thicker base, correct? A fibrous tissue is there. Even if you try, the patient will slap you without LA. Okay, so it's not always without LA. It has to be looking into the tissue type and the consideration, you can say. This is crown lengthening. This is a very common thing. In day-to-day practice, what you do? Why do we do crown lengthening in the first place? Why do we require restorative crown lengthening? To get a proper margins, that's fine. Margins I can get a very small crown height also, but basically to address the non-retentive or retention issues. So what we do is, if we get at least a clearance or a good height of 1 and 2 extra millimeters, the crown retention and resistance forms increases like anything. Correct? So for proper rehabilitation and restoration, we require crown lengthening procedures, and it is very common nowadays. It is not that a patient will come up with a complete crown with all the sun enamel and denting to you for a crown and a root canal. Correct? It's not right. So after checking, so there's one thing. There's one thing which is restorative crown lengthening, and there is one thing which is aesthetic crown lengthening. Correct? Restorative crown lengthening or a soft tissue crown lengthening depends on the biological width. Ever heard of this term, biological width? Yes. Biological width is something that, or in layman terms, it's a breathing space that you want to give to your gingivas. So that whenever you're doing any form of restorations, let it be veneers, let it be normal crowns, if they encroach, you will get to see all the inflamed linings all around your crowns. Okay? So if your biological width is retained, or if your biological width of 3 millimeters, roughly approximately 3 millimeters, if it is retained, and then you have an excess amount of soft tissue, go ahead and do it with your diode lasers. But what if you are already encroaching on your biological width and you still need to do a soft tissue or maybe a crown lengthening which requires, let it be aesthetic or restorative, you have to go and do a osseous contouring also. Now, when I need to do osseous contouring for any form of teeth, I would go back and do with my hard tissue lasers. Correct? So first, this is just when I am doing it for soft tissues. So this, which laser am I using? It is a diode laser. Okay? The infrared, it's a near infrared laser with a wavelength of 980 nanometers. Okay? Okay? We followed it with a postal core and then a crown over it. And this is when we don't have enough biological width, we don't have excess of soft tissue gingiva to cut through. and still we want an aesthetic pleasing smile, correct? This is a case of gingival gummy smile, excessive over gingival display. This was the first case that we did with hard tissue lasers way back then, and we published it. So basically, this was a gummy smile. When you smile, you can see excess of gingival gummy display, correct? If you see what you mean by excess of gummy gingival display, it means your teeth are looking very small and your gums are over displayed, correct? For that, for the first time we did it with stent. We prepared a stent, we marked, can you see this margins, little here? We marked, we removed the soft tissues. We got a good height. But can I stop here? Having said that, my biological width is now not in place. Will I stop there? No. What will I do? I'll go back and check and do a bone sounding thing. I can hit the bone. Can you see the white blanching over there? This blanching is because I'm hitting the bone. My bone is just next to the gingival level. Then we did an osseous crown lengthening and now got a minimum sulcus depth of 3 millimeters, which is equivalent to my biological width. And now my restorations and my gummy smile display is increased. This is just after it has a follow-up. And after that, the patient has got the full complete veneers. So this is a video of how I'm doing a closed flap osseous crown lengthening without even raising flap, without even doing an incision, without actually going into all that traumatic procedures, just by taking the advantage of what my sulcus looks like, we can go ahead and perform a closed flap osseous crown lengthening. This is possible only because of my urban laser. So this is another gummy smile correction case along with there's another case wherein the patient only complained that she had a canted smile. She's not looking and bothered about the teeth. As a dentist, obviously we advise her to do whatever she requires. But she says, Doc, my teeth are fine. I don't know why my smile is canted. Then, just by doing a soft tissue crown contouring her, you can see the cant of her smile is much reduced and she was much happy. We just did this and we actually respected her wish of not doing anything for her teeth. Imagine what? We just did a soft tissue crown lengthening. She came back, she went ahead for complete smile makeover, and we got to do all her videos. So even if there are situations where you need and the patient needs a lot of work to be done, but if you value and respect their feelings, they would definitely and give the corrections what all you address their chief complaint, they would definitely come back with what they want and what you wanted to give them. Lip depigmentation case with lasers. This is abrasive motions. This is immediately how it looks. The only catch here in lip depigmentation case is you have to instruct them that for another 7 days, either you have to be home or you have to pretend that you're having cough or cold because you get a crusted lips. And after 10 days or 7 days, you get a complete decline. This is before and after. Thank you so much. For any details, you can contact me. Thank you. Thank you so much. Thank you so much, ma'am, for this amazing and wonderful lecture. Now, I would like to invite Dr. Neeral Thakur, ma'am. She is an assistant professor at Narsibhai Patel College, Visnagar, and a practitioner in oral medicine and radiology. And her topic is going to be CBCT 1. So over to the ma'am. Thank you.
Okay, thank you so much. A very good evening, one and all. Well, I have not been allotted with much time, so I'm just going to finish it in brief. All right. So, when we always believe in upgrading ourselves, right? No matter even if it's in a gadget or even a trending reel, right? अगर trending reel देखा तो यार हम क्यों पीछे रह जाए, है ना? So we always need to upgrade ourselves. Then why not in dentistry? Why 2D when we have 3D? Correct? So the future of dentistry, that is digital. So today I'll just go in brief about CBCT in dentistry. So basically radiology is one that important part in diagnosis of any of the pathology in dentistry, correct? So in this CBCT is one that important part which has been called as the third eye of dentistry. So CBCT basically gives us the 3D images of teeth, then bone in the maxillofacial region, nerve pathways as well as the maxillary sinus in just one single scan. Now we'll see that how CBCT works. We have 4 steps: image acquisition, then the detection, reconstruction stage, and the final one, that is the image display. So image acquisition, here we could see how the X-ray source that pass to the object, we have the FOV wala option that doesn't we have in the MDC. So here we could just select the FOV, the area of interest that we just need to see. We can just select that particular area of interest. So the detectors would just obtain the image and that would collect the data. So that is the image acquisition. Next. And the cone beam, that is the continuous beam of radiation or the pulse beam of radiation. Second stage, as I said, the detectors which obtain the images. So the detectors that are used, image intensifier tube or the charge coupled device detectors combination. Next one, that is the flat panel detectors. Here we could see the field of view as I have talked in the previous slide, FOV. So here if we just want to see the particular area, we can select that area. If you want to see both the jaws, we have to select that particular area. If we just want a single jaw, we have to select that single jaw. So same ways, the area of interest, एक बार देखना तो वो single भी हम select कर सकते हैं. Okay, so that is the advantage of CBCT. Next. Okay, so the third one, reconstruction stage, where we could see after the image collection, there would be the reconstruction. Okay, so the filtering out of the data. And here it follows the FDK method. And the last one, that is the image display, where we have this benefit, the multi-planar reformation. The 3D image you could see afterwards all the different sections, the axial, sagittal, as well as the coronal. So we have the sectional views. Okay. So this is the axial section. Next would be the transaxial section. If you want to see the maxillary area, we can just select the maxillary part and you will just get the different views. Same goes for the mandibular area. So the 3-dimensional mode, the volume rendering modes. So if we want to see the bony area, we have that particular mode, correct? If the soft tissue, we have to select that mode. Then the airway mode. So this is for the bony part. Next, this is the soft tissue. This is for the airway mode. In the cases like sinusitis, we want to see whether if there is any kind of obstruction or not, then we have to select that particular mode. Okay, so medical CT and CBCT. So in medical CT, as I have said previously, correct? If we just want even one particular area, we have to scan the entire area. Whereas in CBCT, we can even select that particular area. So yes, going to the advantages, rapid scanning time, right? Less than just 1 minute. Beam size that would be smaller according to the FOV. Patient radiation dose that would be reduced like approx 1/10 than that of the conventional CT. Now everything has their pros and cons, So these are some of the limitations, the cone beam artifacts. So during that acquisition stage, when the X-ray source would be passing through the object, so that object would be stagnant, okay? Detectors would just capture the images and it will just collect the data. Then it would follow that 360-degree rotation. So during that rotation, the object would definitely be stagnant, but the X-ray source would be replaced by detectors, and detectors that would be replaced by X-ray source. So it will target a particular area. Okay, so that targeted area would be exposed twice. So that will lead to an artifact. And the second one, that is the poor soft tissue contrast. So which is a benefit in the MDCT. MDCT has good soft tissue contrast, whereas in CBCT, it is not. But as we follow the Alara principle, as low as reasonably achievable. So exposure dose that would be like 78 to 86% less than that of the CT. And it is even time scanning. It will minimize the risk of the motion artifacts. Some of the applications in the dentistry. As we all know, during the implant planning, no matter even if it is single or multiple, conventional or basal, we need to go for CBCT. Same way as impacted canine or the wisdom tooth. Before the disimpaction procedure, we definitely need to plan for the 3D view. Any of the complicated endodontic cases or the periodontitis, any cyst, tumor, or the trauma cases, TMJ disorders, or during any kind of the syndromes. I'll just go through the cases one by one fast. Implant planning, here we could see 3536 missing. So we have just gone for the CBCT. So here you could see the different colors that shows the density of the bone. Okay, it ranges from D1 to D5. So the best quality, if we get the best quality, then we can definitely plan for the implant procedure. Correct? Here we could even show it to the patient that how we could plan the implant procedure. Right? We could show it to the patient. Next. This is an IOPA of radicular cyst. Well, the anterior portion is quite hazy, so we need to go for the 3D view. That will just show the proper extension. So here we could see the perforation, the buccal plate perforation well in the CBCT. To show the cases. This is the case of carcinoma. You could well appreciate the floating tooth as well as the destruction of bone, buccal and the lingual plate perforation. Okay, here impacted 3-3 and 4-3. So to see for its positioning, we need to go for the 3D view. Same way for the wisdom teeth removal, before planning the disimpaction procedure, to see the close relation of root with that of the nerve canal, we definitely need to go for the 3D view. Next. This is the case of advanced periodontitis. So before planning the bone grafting procedure, to see how much area needs to be, need the treatment part, we need to go for that. Same ways for the tooth fracture. This is a case, endodontic case. So for better access to all the canals, like palatal canals, to visualize that, we need to go for the 3D view. So now you will see in the next picture how beautifully you can just see all the canals, like mesobuccal 1, 2, distal 1, 2, as well as the palatal 1 and 2. This is a case of parasymphysis fracture. Okay, ankylosis, where you could just appreciate how the condylar head has been fused with the glenoid fossa. This is the multiple supernumerary tooth, which is associated with a syndrome because it is very rare to observe, like without any syndromes, you can't just find multiple supernumerary teeth in any of the patient. So that was the case of the cleidocranial dysplasia, where there is a hypermobility of shoulders as well as the absence of clavicle. Alright, so ending this lecture, before it was like, we need to get the print, then we need to plan the entire treatment, the entire procedure, and then we need to implement it on the patient. Whereas now, we just used to scan, we have the surgical guide, the guided stent, we just place it in the patient's mouth, and we just place the implant without any fear. Correct? So this is how CBCT is very much beneficial in our daily practice. These are my references. Thank you so much.
Thank you so much, Neeral Hathaman. Now I will invite Dr. Shailja Hathaman. She is the Dean in Narsibai Patel Medical College and MDS in Oral Surgery. Over to you, ma'am. Good evening, everyone. I'm not going to take much time because I know people are all running over time. Okay, today everybody is talking about different things that can be used in dentistry. Where the evidences from dental and oral structures are used. And tooth is one of the most important structures that is being studied in forensics. Okay, it's important because it's a very robust material and it can withstand temperature of even 1600 degrees without showing any microstructural changes. Okay, these are the things which is called as big F in biological identity forensics. Okay, we can do morphological as well as molecular analysis. Okay, now when we talk about pulp, what is pulp? Pulp is a soft tissue that is nicely encased within enamel and dentin. So it's very, very safe. It doesn't easily get destructed. It doesn't easily get infected. Okay, so these are different things that can be identified with our dead pulp also. First is blood group identification. As in any other forensic investigation, with a clotted blood group identification can be done by absorption elution method. Important here, what I want to tell is, a dead pulp from a dead tooth can tell you the blood group of the deceased individual even after 2 years of death. Okay, this is the point I want to stress. Next is determination of gender. Okay, the first one is bar bodies that can be identified in a pulp. Okay, the bar bodies, what are bar bodies? These are, bar bodies are the inactive X chromosome that is seen in a female somatic cell. Next. Okay, these are different pictures that are taken from the pulp tissue. Okay, which is showing the bar bodies. The first one is an HND stained tissue. The second one is Fusion reaction wherein the nucleus is stained. And the third one is acridine orange staining. It is being circled and you can note the bar body seen in its markers. Similarly, as we can identify a female, we can identify a male, wherein we are staining for F bodies. The other gender typing methods using DNA can also be done. The next one is age estimation. We can use morphological, radiological, or molecular method. Next. The most Okay, now when we are doing age estimation, what is important is a young pulp is bigger in size and you have lot of cells in it, less of collagen in it. Okay, secondary dentin is being formed continuously even after birth, even after the tooth is erected completely. This deposition of secondary cementum will increase the thickness, secondary dentin will increase the thickness of cementum, reduce the size of the pulp. So all these things can be used to estimate age. One is pulp tooth ratio, wherein you use digital, panoramic, as well as CBCT to identify, wherein we can study the size of the pulp and area of the pulp, perimeter of the pulp, compare it with that of the tooth, as well as the height of the pulp. A young fibroblast is plumpier, stellate shaped. A older fibroblast is smaller, spindle shaped, and stains darker. The number, function, and activity of odontoblast will reduce with age. Next is the study of telomeres. It is said that as the cell increases its age, the cell divides multiple times, the telomeres become shorter. And they will reach a stage wherein the telomere is so short that it will not allow cell division. So, the length of telomere can help in the determination of age. The next one is the study of interval of death. Okay, that can be done with pulp as well as the density of odontoblast. The last one that can be done for individual identification is DNA profiling. Okay, it's also called as DNA printing, DNA testing, as well as DNA typing. So these are the factors that will influence how and what quality of DNA that can be obtained. It has three procedures: cell lysis, protein denaturation, and isolation of DNA. Different DNA profiling methods are these listed. And now when we have the DNA profile that is done, we will study either the variable number, long tandem repeats, or short tandem repeats. This is important because no two individuals other than identical twins can show similar DNA profile. That's the reason it is very important. To conclude, I want to tell that pulp is such an important thing. It's well protected. It can be used for a longer time. Even after 2 years, it can give a lot of information about the deceased person. So that's the importance of pulp. It's definitely very important in a living person. It's also important even after death. Thank you for your patience. Now I would like to invite Dr. Balasubramanian ma'am. Now I would like to invite Dr. Vinayaka A. I would and also Dr. Neeraj Dhawan ma'am. Now Dr. Shalin Kalsta ma'am. So thank you. That's all. And now there will be other ceremonies. Now there will be an award show. Okay. Thank you.
A very good evening, ladies and gentlemen, friends and colleagues, and all dear delegates. Once again, this is Dr. Aditi Nandai.
And this is Dr. Pradeepam.
Welcoming you to this extravagant evening of the World Dental Excellence Awards, recognizing and honoring the stars of dentistry, organized by CynoDent International and ISD.
It is with the divine grace of Almighty that we have been able to come this far today. I congratulate Dr. Anmol Bagadia, CEO, Team CynoDent International, President, Indian Society of Dentistry, along with Dr. Ashish Chandra Pandey, Director, CynoDent International, and Vice President, Indian Society of Dentistry, for this grand success. Please put a huge round of applause for this complete team, ladies and gentlemen.
कभी बचपन कभी जवानी है, गुजरती इस तरह जिंदगानी है। कौन किस पर मेहरबान होता है यहाँ, आप सब यहाँ आए ये आपकी मेहरबानी है। We feel immensely honored to have amongst us the charismatic array of luminaries. I extend my heartiest welcome to Honorable Chief Guest Dr. D.N. Kapoor, legendary orthodontics. Our worthy special guest Dr. Ramesh, Chief Income Tax Commissioner. Ladies and gentlemen, please put a huge round of applause. And our worthy special guest, Dr. Sunil Pandey, former DGP, Gujarat.
There is this age-old quote in English that all birds find shelter during the rains, but only eagles avoid rain by flying above the clouds. So problems are common to all, but attitude is what makes the difference. Today, we have gathered here to honor the exemplary and the very inspirational personalities of our dental fraternity who work day in and day out at our ground level and have done some amazing work in their respective fields.
As I said this afternoon, appreciation can change a day and even change a life, but your willingness to put it into words is all that matters. This award show is CynoDent's small initiative to acknowledge and honor the hard-working dental fraternity on the road. We have various categories nominating working dental fraternity, dental students, clinicians, academicians, and of course, the foundation stone of every dentist education, the dental colleges of India. So without further ado, may I please invite upon Dr. Anmol Bagadia and Dr. Ashish Chandra as we proceed for the award ceremony. Please put a huge round of applause, ladies and gentlemen. And what better to start a ceremony with the blessings of a guiding light and our truest well-wisher. Ladies and gentlemen, please put a huge round of applause as I most humbly request Dr. D.N. Kapoor to please join us for the award ceremony. Sir, we are obliged and deeply indebted to you for your gracious presence once again this evening. Thank you so much. We now request a felicitation to please be accorded to Dr. Ramesh, Chief Income Tax Officer. Ladies and gentlemen, please put a huge round of applause. Thank you, sir. We extend our heartfelt gratitude to you for gracing us with your presence.
I request all the delegates at the back seats to kindly occupy the front seats towards my right and towards my left so that we have a good show. Everybody at the back. Big round of applause, ladies and gentlemen. Thank you so much, sir. Now we are beginning with our award ceremony. May I now invite upon Dr. Kamal Bagla, sir, to kindly do the honors. Dr. Kamal Bagla, sir.
The first and a very special award, Facial Cosmetic Surgeon of the Year Award, and it goes to Dr. Athreya Rajgopal. Please put a huge round of applause, ladies. Our next award is called Emerging Oral Medicine and Radiologist of the Year. And the award goes to Dr. Piyush Sivare, sir. Please put a huge round of applause.
Dr. Piyush Sivare, sir. Our next award is for Emerging Oral and Maxillofacial Surgeon of the Year, and the award goes to Dr. Setu Shah. Dr. Setu Shah, Emerging Oral and Maxillofacial Surgeon of the Year. Thank you, sir.
The Young Researcher of the Year in the category of periodontology. The award goes to Dr. Vinayaka A.N.
Dr. Vinayaka.
Next is the Heroic Dentist of the Year award. The award goes to Dr. Imran Khan, sir.
Dr. Imran Khan for Heroic Dentist of the Year.
Next we have the Best Endodontist of the Year award, and the award goes to Dr. Promila Verma.
Dr. Promila Verma, ma'am, Best Endodontist of the Year. Big round of applause, ladies and gentlemen. Our next award is for the Best Prosthodontist of the Year. And the award goes to Dr. Nikhil Verma. Dr. Nikhil Verma.
Another award in the category of Heroic Dentist of the Year, Dr. Juga Jyoti Patil. Star Dentist of the Year award, Dr. Pavitra Rastogi, ladies and gentlemen.
Dr. Pavitra Rastogi, sir. Star Dentist of the Year. Our next award is for the most popular celebrity dentist of the year, and the award goes to Dr. Sagar Abhichandani, sir. Big round of applause.
The Student of the Year award for BDS final year, Goldie Shaji.
we have Dr. Sagar Abhichandani with us, the most popular celebrity dentist of the year. The award goes to Dr. Sagar Abhichandani, sir. Dr. Sagar Abhichandani. I thank all the dignitaries for doing the honors. You may please occupy your seats in the audience. Thank you so much, sir. I request Dr. Shalin Chandra, sir, to please do the next honors. Dr. Shalin Chandra, sir. I request Dr. Pavitra, sir, to please join us on stage.
We next have Student Dental Talent of the Year Award, and the award goes to Dr. Anam Siddiqui.
Dr. Anam Siddiqui.
Please put a huge round of applause, ladies and gentlemen. Budding Practitioner of the Year Award, and the award goes to Dr. Abhishek Dubey. Please put a huge round of applause.
Dr. Abhishek Dubey for the Budding Practitioner of the Year.
The Intern of the Year Award goes to Bhumika Solanki and Rajkumar.
Bhumika Solanki and Rajkumar, Intern of the Year 2022.
The Budding Internist of the Year Award, Dr. Lakshmi Pandey.
Dr. Lakshmi Pandey for Budding Endodontist of the Year. Dr. Lakshmi Pandey for Budding Endodontist of the Year. Our next award is for the Dental Talent of the Year, and it goes to my co-host Dr. Aditi Nanda. Dr. Aditi Nanda. Thank you so much, Pavitra sir and Shalin sir. I now request Dr. Mihir sir and Dr. Viral sir to kindly do the next honors. Dr. Mihir sir and Dr. Viral sir. Our next award is for the Best Inspiring Couple Dentist of the Year, and it gives me a great privilege and honor to invite Dr. Mayur Kaushik and Nupur Kaushik ma'am for the award. Dr. Mayur Kaushik and Dr. Nupur Kaushik ma'am. Best Inspiring Couple Dentist of the Year. Big round of applause, everybody.
Passionate Dentist of the Year Award.
Our next award is Dr. T.N. Kapoor Institutional Excellence Award, UP Zone. It goes to Institute of Dental Studies and Technologies, Uttar Pradesh. Institute of Dental Studies and Technologies, UP, Modinagar. I request Dr. Ashish Chandra to please collect the award on his colleague's behalf. Big round of applause, everybody.
We next have Best Teen of the Year award, and the award goes to Dr. Pristine Enamel.
Dr. V.
Round of applause, ladies and gentlemen.
Dr. V. Srinivasan, sir, Best Team of the Year.
We next have the Best Oral Pathologist of the Year award, and the award goes to Dr. Venkataya Subramanian.
Dr. Venkataya Subramanian, Best Oral Pathologist of the Year. They are on the okay.
The Budding Endodontist of the Year award, and the award goes to Dr. Soumya.
Dr. Soumya, Budding Endodontist of the Year.
She's practicing since 19 years, ladies and gentlemen. After this is the time for the most awaited award of the evening, ladies and gentlemen, the Lifetime Achievement Award.
I request everybody in the audience to kindly stand up for this award. This is the Lifetime Achievement Award, which goes to Dr. T.N. Kapoor, sir. A huge round of applause, everybody. Dr. T.N. Kapoor, sir. I request.
सौ चांद के चमके तो क्या बात बनी, आप यहाँ आए तो इस रात की शान बनी. Ladies and gentlemen, once again, please put a huge round of applause for Dr. T.N. Kapoor.
Our next award is for the Emerging Practitioner of the Year, which goes to Dr. Milan Ogreja. Dr. Milan Ogreja.
Our next award for research in the field of endodontics, and the award goes to Dr. Kailash Atul.
Dr. Kailash Atul. Our next award is for Emerging Orthodontist of the Year, and the award goes to Dr. Chaitali Parikh. Dr. Chaitali is there. Wonderful. Our next award is for the Company Partner Award, and it goes to Mani India. Team Mani. Our next award is for the Outstanding Academician of the Year, and it goes to Dr. Shalini Chandra sir. Dr. Shalini Chandra sir. Huge round of applause, everybody. Our next award is for the Best Researcher of the Year, and it goes to Dr. Kaushal Kishore Agrawal. Dr. Kaushal Agrawal.
The next award is Budding Practitioner of the Year award, and it goes to my co-host, Dr. Pradeep Kaum. Please put a huge round of applause. Dr. Pradeep Kaum, ladies and gentlemen. The next award is Budding Academician of the Year award, and the award goes to Dr. Sarita Bhattari. Dr. Chitali is going to receive the award on her behalf.
Dr. Sarita Bhattari for Budding Academician of the Year. Dr. Sarita Bhattari. Our next award is for Emerging Orthodontist of the Year, and the award goes to Dr. Chaitani Parekh. Emerging Orthodontist. Huge round of applause. Dr. Chaitani Parekh. Thank you so much, Dr. Mihir sir, Dr. Viral sir. Thank you for doing the honors. I now request Dr. Atharya Rajgopal sir and Dr. Amit Bhardwaj sir to kindly do the next honors. Dr. Atharya sir and Dr. Amit Bhardwaj to kindly do the next honors. Our next award is for the Young Researcher of the Year in Female category. It goes to Dr. Anu Vashish. Dr. Anu Vashish.
We next have the Best Student Community Service Award, and the award goes to Dr. Noman Sheikh.
Dr. Noman Sheikh for the Best Student Community Service Award. Our next award is for the best teen of the year. Best teen of the year, and it goes to Dr. V. Srinivasan sir. Huge round of applause, everybody. Best teen of the year, Dr. V. Srinivasan sir. Our next award is for the Emerging Oral Medicine and Radiologist of the Year, and it goes to Dr. Piyush Shivare. Dr. Piyush Shivare. Emerging Oral Medicine and Radiologist of the Year.
The next award is Young Researcher of the Year Award in the male category, and the award goes to Dr. Yash Sharma. Dr. Yash Sharma, ladies and gentlemen, for the Young Researcher of the Year Award in the male category.
I thank Dr. Atharya sir and Dr. Amit Harwar sir for doing the honors. For our next honors, may I please request Dr. Desai sir, Dr. Desai sir, Dr. Adarsh Desai sir. And Dr.
The next award is Dental Leadership Award, and the award goes to Dr. Anshuman Maheshwari.
Dr. Anshuman Maheshwari sir for the Dental Leadership Award. Big round of applause, everybody. Our next award is for the best college in the field of research, and it goes to Dental College, Gopal Guma. Gopal Guma, Dental College. Gopal Guma, I'm sorry. Gopal Guma. Dr. Setu sir will collect the award. Our next award is for the best cosmetic dentist of the year, and it is my proud privilege to invite Dr. Rumpa Vignan for the award. Best cosmetic dentist of the year. Our star speaker, Dr. Rumpa Vignan. Huge round of applause, everybody.
Soumya Johri.
Dr. Soumya Johri.
ladies and gentlemen.
Thank you so much, Sagar sir and Desai sir. Thank you so much. Thank you so much, Sagar sir and Desai sir. For the next honors, I would like to invite Dr. Srinivasan sir and Dr. Mayur Kaushik sir. Dr. Mayur Kaushik and Dr. Srinivasan sir to please do the next felicitations. Our next award is for the Emerging Pedodontist of the Year, and the award goes to Dr. Mangetri Fasale. Dr. Mangetri Fasale. I hope I'm pronouncing it right. Dr. Mangetri Fasale.
The next award is Best Implantologist of the Year award, and the award goes to Dr. Viral Patel. Dr. Viral Patel, ladies and gentlemen. Our next category is Best Laser Dentist of the Year award, and the award goes to Dr. Shannon Fariska.
Dr. Shannon Fariska.
Next we have the Outstanding Contribution in the Field of Dentistry, and the award goes to Dr. Girish Parmar.
Dr. Girish Parmar.
We next have Outstanding Dental Leadership of the Year award, and the award goes to Dr. Dolly Patel.
Dr. Dolly Patel. Our next award is for Emerging Public Health Dentist of the Year, and the award goes to Dr. Nayan Patel. Dr. Nayan Patel.
Our next award is Best Public Health Dentist of the Year award, and it goes to Dr. Harsh Shah.
Dr. Harsh Shah.
Huge round of applause, ladies and gentlemen.
Our next award is for the Outstanding Practitioner of the Year, and the award goes to Dr. Mihir Pandya. Dr. Mihir Pandya for the Outstanding Practitioner of the Year. Thank you so much, Srinivasan sir and Dr. Mayur sir, for doing the honors. I now call upon Dr. Pramila Verma ma'am and Dr. Rupavik ma'am to kindly do the next felicitations.
the Year award in the oral surgery category. And the award goes to Dr. Adarsh Desai.
Our next award is for the outstanding contribution to the field of dentistry, and the award goes to Dr. Girish Parmar sir. Dr. Girish Parmar. I request Dr. Sujay Parkar to please collect the award on his behalf. Dr. Sujay Parkar. Dr. Girish Parmar for outstanding contribution to the field of dentistry. Huge round of applause, everybody.
We next have the Best Dental Clinic of the Year award, and it goes to Dr. Bindi Pandya.
Dr. Bindi Pandya for the Best Dental Clinic of the Year. The world has seen a lot in terms of suffering and health. So, our next award is the Corona Warrior Award, and it goes to Dr. Charvisha Agrawal. The Corona Warrior Award. Dr. Charvisha Agrawal.
We next have the Budding Endodontist of the Year award, and it goes to Dr. Akshita Panchal.
Dr. Akshita Panchal.
We next have the award for outstanding contribution in the field of endodontics, and the award goes to Dr. Kamal Bagda. Huge round of applause, everybody.
Our next award is for the Student Community Service Award in the female category, and it goes to Ms. Misbah Qadri. Misbah Qadri for Student Community Service Award.
We next have the Emerging Dean of the Year award in the female category, and the award goes to Dr. Bala Sundari, ladies and gentlemen.
Emerging Dean of the Year in the female category, Dr. Bala Sundari ma'am.
We next have the Best Dental Photographer of the Year award in the junior category, Dr. Vaibhav Nakun.
Doing a lot of hard work, Dr. Vaibhav Nakun. next award is for the best aesthetic dentist of the year, and it goes to Dr. Parmeet Panga sir. Dr. Parmeet Panga sir. So our next award is for the best private dental college in Gujarat. It goes to Goenka Research Institute of Dental Sciences. I request Dr. Kamal Bagra sir, Dr. Desai sir, to please select the award. Goenka Institute of Research.
Research Institute of Dental Science.
Dr. Kamal Bagra sir, Dr. Desai sir.
We request Dr. Bagra and Dr. Desai to please stay put for the big revelation.
We have our next big revelation. It is with a great sense of gratitude and pride that Goenka Research Institute of Dental Sciences is starting with its own journal by the name of Journal of Global Research in Dental Sciences. For Goenka Institute. It is a biannual journal, online journal patented by Mr. Apurva Goenka. With this, we are adding another feather to the cap. Please, ladies and gentlemen, put a huge round of applause. I would like to invite the chief editors of this journal, Dr. Kamal Bagra sir, Dr. Adarsh Desai sir, Dr. Uday Patel sir. I would also request the other editors of this journal, Dr. Charu Agrawal ma'am, Dr. Mihir Pandya sir, Dr. Sonal Chhajet ma'am, Dr. Tapish sir, to please join us on stage. It's a proud moment for Goenka Institute. And as Amitabh Bachchan says, तालियां बजती रहनी चाहिए. Journal of Global Research in Dental Sciences by Goenka Institute. Three cheers for Goenka Institute. Huge round of applause. This journal has been released in the 5th World Dental Sciences and Oral Health Conference by CynoDent International. And also the first Global Dental Synod Grids. Huge round of applause for both the teams. Thank you so much, everybody, for joining us at the inaugural ceremony of this journal. I wish Economica Institute may rise day in and day out in the eternity. So for the last award, it is AMA felicitation for the wonderful venue that we are having a conference on. AMA is one of the promoters and the founders of All India Management Association, the apex body for the management of the profession in India, and has been actively collaborating and participating in educational and professional activities offered throughout the country. AMA is also an ISO 9001 certified organization and an approved institute for management training by the government of Gujarat. Established in 1956 by Dr. Vikram Sarabhai, the father of India's space program and other professionals, AMA has been providing an active regular forum for professionals in Ahmedabad through lectures, discussion meetings, management development programs, industry visits, and publications. AMA has received 16 times from 1990 to 2008 the Best Local Management Association Award, Category 1 by All India Management Association for its outstanding contributions in professional management. So in fact, the initials AMA well stands for Always Moving Ahead. A big round of applause for AMA.
We have Dr. Vinayak with us, ladies and gentlemen, and he won the award for Young Researcher of the Year in the Periodontology category. Huge round of applause.
Young Researcher of the Year in the field of periodontology. Also, the speaker felicitation was pending Dr. Vinayaka came for his topic lasers.
We next have the Heroic Dentist of the Year award, and the award goes to Dr. Imran Khan. Huge round of applause.
Dr. Imran Khan for the Heroic Dentist of the Year. Thank you so much, Pramila ma'am, Dr. Rupa ma'am, for doing the honors. With this, we come to an end to our award ceremony. I congratulate all the nominees and the award winners. We all are winners. With this, I would like to invite Dr. Anmol Bagadia. We have Dr. Shannon Farista ma'am with us, and she has won the Best Laser Dentist of the Year award. Dr. Shannon Farista ma'am. Dr. Shannon Farista.
Huge round of applause, everybody.
I wholeheartedly apologize if we have missed out any names. You can let us know backstage.
Thank you so much, ma'am. With this, we mark the end of our award-giving ceremony. And always remember, participation is better than winning. With this, high hopes and high spirits, we mark an end. Now I request CEO CynoDent International, Dr. Anmol Bagadia, to please award a vote of thanks. We request Dr. Anmol Bagadia and Dr. Ashish Chandra to please extend a vote of thanks, and we request Dr. D.N. Kapoor sir to please be seated. Thank you so much, sir, for your gracious presence.
Good evening, everyone. Thanks for joining us this evening. And I would congratulate all the winners and participants. Thank you for your enthusiasm and participation in the award show. And I would request all the guests to proceed for the dinner. And I have an announcement for the students that 29th, tomorrow evening, we are having a DJ night at Golka Dental College from 7:30 to 9:30 p.m. And we will be arranging the transport facilities, and it will be hosted in Golka Dental College, and it will be the part of this event as we have named it Cynoforia 2022. Thank you, everyone. I would request all the dignitaries, all the guests, all the delegates to proceed for the dinner. Thank you, everyone.
I request all the members of Team CynoDent International to please gather upon stage for a group photograph. All the members of Team CynoDent International to please gather upon stage.
We request the entire team of CynoDent International to please ascend upon the stage for a group photograph.
Yeah.
We request the team CynoDent to facilitate Kalinga University for the best university in India. And we request Dr. Usha Pagaria to please receive the award on their behalf. Huge round of applause. Usha ma'am has been a pillar of strength for the entire preparation. Thank you so much. I request the entire team of CynoDent to please come upon the stage. We request the team Goenka to please wait for the photograph. Team CynoDent, Anam, Noman, Lakshmi, Abhishek sir. Everyone please come upon the stage. Sarita ma'am, Anu ma'am. We request Team Goenka to please ascend upon the stage for a group photograph. Team Goenka, ladies and gentlemen, a huge round of applause.
पीछे आ जाओ भैया, वो वापिस आ जाएगा, वापिस पीछे अब आज फ्रेम में आते हो नहीं देखा था बता गाड़ी खसड़ो बता
Sir, please, everyone. Yes, sir.
तो ये सर तो बाजू में मजा आ रहा है
Hold on. Hold on. Wait. 1, 2, 3. Ready? Ready, everyone? Sir, sir. One, two, three. Okay, okay, thank you. Light one.